cannot see it. Okay, that was my concern. All right, well, I'll work on that during our first break. Let me set my timer for 50 minutes. All right, and then we'll take a 10-minute break. So we're just going to review the PowerPoint. Minimize screen share. Before I do that, there was like a summary of polishing, and this is a really good summary. There were a lot of articles on polishing. They say pretty much the same thing as your PowerPoint. You know, this kind of is your PowerPoint is broken up into little bits. You know, each slide is addressing a different part of this. If you want to kind of pull things together as a review, just reading through this one time will help you study for your polishing quiz. But the quiz is not just polishing. It's going to be dental stains. What are stains? What are different types of stains? So this mostly is just about polishing, and not so much about dental stains. But you know, this is a good kind of review, and that flossing is part of polishing. Goes through the steps, shows you how the cups kind of flare interproximally. So, you know, it's a pretty lengthy little thing. A lot of it, once you get into it, is pictures and not all, you know, just constant reading, but especially as you get further down. But this is a good little review. You know, I'm not going to ask you what do you polish first and how, you know, how do you polish the maxillary right posterior. That's not part of the polishing quiz you're going to have in a little bit, but this is kind of a nice review. It talks a little bit more about the air powder polisher, which, you know, you won't learn about until next semester. The angles, you're not going to be quizzed on the air powder polisher techniques or anything like that, but just wanted you to know that article was there. You don't need to memorize it or anything, but it is a nice little kind of summary review, and it goes into a little more information. All right, so let's go to the PowerPoint. Wait for it to load. All right, I don't know why it's loading weird. If you cannot see this, please let me know. It looks like it's sharing okay. So, introduction to engine polishing. It's the removal of extrinsic stains and soft deposits that we cannot remove with toothbrushing or scaling. It's a cosmetic procedure. It is not therapeutic. When we use our instruments to remove the bacteremia, the layers of bacteria that's soft and hard, we are increasing the health. That's therapeutic. We're providing a procedure, a service that will benefit the patient's health, improve their health. Polishing, for the most part, is considered just makes the teeth look better. It's a cosmetic procedure. It's considered, last bullet here, a non-essential. No therapeutic effects benefit because stains do not directly contribute to periodontal disease, caries, which are cavities, or any other oral disease. So we're doing this just for the benefit of the patient's appearance. It does remove extrinsic stains, the aesthetic purpose and motivation of the patient. So say you have a patient who hasn't been to the dentist in 4 or 5 years, just whatever reason didn't get there financially, they moved, needed a new dentist and just kept forgetting to do it, whatever. And they just have let their home care go. Well, once you remove all that stain and the teeth just look better and brighter, and they are going to feel better about their self typically, because all of that discoloration has been removed. They will want to maintain that, especially if you give them some good techniques and discussion with the home care. And then hopefully will help motivate them to come in regularly so things don't get out of control that could lead to gum disease or lead to caries because they go long periods without professional intervention. So, it does have its benefits, even though it is just cosmetic. It can have a mental benefit for the patient as motivation. Their teeth feel cleaner. They want to maintain that. They're motivated after their appointment to floss regularly, even though that might phase out. Eventually, maybe it won't. Maybe they will continue to floss regularly. Sometimes it just takes time for a patient to get on board with what they need to do. It has to be the right time in their life. And this is always a motivator. This is the time your teeth are clean. So, even after all that scaling we do and all that hard work, which is, say it's a 50-minute appointment, we spend 25 minutes scaling and 5 minutes polishing. It's that 5 minutes of polishing when people run their tongue around their teeth that they feel the most, okay, I just had my teeth cleaned. If you just did the 25 minutes of scaling and not the 5 to 7 minutes of polishing, they would feel that their teeth were not clean. They didn't get the trophy, the cleaning that they had come to the office for. It's kind of a conundrum for us because we work so hard with the other part, but that's sort of the final step when patients can kind of run their tongue around their teeth and they're like, things are slick and smooth and feel good. Another reason to polish is we can use pastes that have fluorides in them and help to, put a little fluoride back in on the tooth. And we can prepare teeth with a non-fluoride paste, a fluoride-free paste, to prepare the tooth to make it super clean to apply sealants to a tooth surface. So there are detrimental effects to polishing. Even though it's only cosmetic, it can harm the tooth with improper, consideration of the patient, the teeth, the gums. So, and it can also increase aerosols and splatter, which is detrimental to us, because if a patient has an active, flu virus, hepatitis B, corona, those aerosols in the air, and if you're talking TB, those aerosols can hang in the air because they're so very, very fine, right? It's not splatter, which is heavier, that sort of shoots out and drops. Aerosols hang in the air, sometimes for up to half an hour time, but definitely for, 15 minutes, the aerosols just hang in a plume, like a cloud, a fog that we can't see. But if we breathe that in, it gets into our eyes. We, are talking and we breathe it in that way, it gets into our lungs. We could get sick. So it's a concern for us. First and foremost, we have to be careful how we polish, especially when you're talking air powder polishers, which have they're like a little mini sandblaster with water and forced air that creates a splatter with a grit in it to polish the teeth. But even polishing, just the nature of the spinning cup can cause the paste to splatter around, and then mix with saliva, you could get the finer aerosols. You could create a bacteremia. So what is a bacteremia? That's where you're gathering the bacteria on the tooth surface or in the region that you're polishing. And because gums bleed, not only is their blood transfer from, the body out of the sulcus to the tooth, and into the mouth from the patient, that opens a pathway for bacteria to travel back. So wherever there's bleeding coming out, a bacteremia or a cluster of bacteria can get in to the patient's body. So if, 99% of your healthy adults, this is not a problem. But if you have an immunocompromised patient, and that's why we don't treat people who have just gone through chemo and their white blood cell count's low, or who have, certain issues. And we're going to learn all about that week 13 and 14 when you guys do your, medical issues, medical conditions, and you're researching, does this condition affect treating the patient? And there are some conditions that do. So a bacteremia, a patient could actually get an infection in a artificial or a weak or fluttery, ineffective heart valve, and that's called bacterial endocarditis, where it actually affects the heart. It's incredibly rare. People who have a heart valve that is so weak or so it regurgitates blood back and forth through the chambers of the heart, right? The blood's supposed to flow in one direction and around and collect the oxygen and out. It's not supposed to go backwards, but sometimes a valve is kind of weak or pulls in and it leaves a little leaky, like a leaky faucet, and blood goes backwards. Typically, those patients are going to have a, some type of intervention with, a medical intervention to correct that. But if not, or if it's undetected, these patients could, in effect, have their teeth cleaned and end up with an infection in the heart. So there's rare times when a patient has to be pre-medicated. And right after a hip or knee replacement, you might hear a surgeon say this patient needs to be pre-medicated for their dental treatment. And the reason for that is if a bacteremia goes backwards through this bleeding gums, it travels through that portal that's open, it could settle in the artificial hip or joint and cause it to fail, cause an infection. So, those are things you're going to be reminding us of, educating us more on when you do your medical conditions. But the polishing as well as instrumentation can create this bacteremia. So if gum tissues have had, some heavy duty scaling, just they were raw to begin with because of the infection the patient came with, we've had to scale or instrumentation to remove these deposits, and that has further agitated the gums. It's recommended that we wait a week after those treatments, have the gums firm, tighten a little bit, be healthier, because polishing will further traumatize these already diseased tissues. Excuse me. So that's what they're talking about here. And an incorrect technique. And we're going to talk about what incorrect technique is, but if you use incorrect technique, you could actually cause, tissues to be damaged. Now they'll heal, but it's not pleasant for a patient to have their gums all sore and swollen from polishing. And we certainly don't ever want to do that. So bullet number 4, the effect on teeth and restored surfaces. You're creating a rougher surface on the tooth or restoration if you use a medium, but especially a coarse grit. So you must be aware that you could create damage according to what grit you select. And if you use it, on a Enamel is very hard, but porcelain and golds are much softer. So if you use it on those crowns that are porcelain or gold or gold MOD restoration, you could actually scratch it and then it would hold more plaque and bacteria and stain after they leave because of what you did, because you scratched a surface that when they came in was not scratched. So, you know, you don't want to create a problem where there wasn't one and weaken a restoration that they, you know, expect you to maintain, not weaken and scratch up. Then the next bullet down, so we're on effects on teeth and restored surfaces. There's the little red bullet, the next one down, removal of fluoride-rich surface of enamel. So every time you polish, if you're using a grit, especially medium, coarse, or extra coarse, the more grit and the more other things we're going to talk about that you do incorrectly will remove a microscopic layer of the tooth surface. So, you know, that's something to think about. If you're just polishing, I know it's not a big deal. It can be a big deal with incorrect paste and grit and incorrect technique. So you must be aware that you're using a very, you know, a very powerful, even though it's a little soft, spongy rubber cup, it can have the power to cause damage if you don't use it correctly. You can damage demineralized areas. So if a patient has had ortho, you know, we've seen the ortho bands on the molars where there's a great big band, there's hooks for rubber bands, and the patient wasn't great about cleaning under that, or some occasions they can't even get to it. And they're in ortho bands for 2 years. I'm talking the metal bands and hooks. They can come out of the other end of that with enamel that's pitted or demineralized. You don't have to have braces to have demineralization. If a child, you know, from 12 to 15, 16, spent those 3-4 years not brushing their teeth well, and they're, you know, they just kind of hit the occlusals and plaque was always sort of in the cheek area of their molars, it would demineralize. We see this with soda drinkers, heavy duty soda all day long, sipping on their soda and multiple sodas every single day. They'll get pitting of the teeth where the enamel is rough and demineralized pitted spots. So if you take a grit on a already a roughened, weakened enamel surface, you could remove more enamel. So, you know, we don't want to further weaken a demineralized area. So that's a big deal. You need to know where the demineralized areas are and probably avoid them with your polishing and just brush them during patient education to remove the plaque, or use a paste that has no grit. If a patient has exposed roots are much softer than enamel. If you're removing some moderate to heavy stain and you selected a coarse grit and you roll down there on that root, you're going to remove microscopically more root surface and give it a little scratched up from your coarse grit that will attract more stain after they leave and more plaque. You've created damage. So, you know, you have a powerful tool in your hand and you need to understand that in order to do the best therapeutic care to maintain the health of your patient and improve the health, not be detrimental to it. If a patient has sensitivity, that typically means they're sensitive to cold air, cold water, things with ice cubes in it, ice cream. Those teeth already are very porous. There's open pores along the gum line. Even if you can't really see the root exposure, there might be a little teeny tiny bit of exposure in between the teeth, maybe a little bit of where that CEJ kind of swoops down on the mesial and distal. On some teeth, it's not straight across. And these patients tell you their teeth are sensitive to cold. You could increase that sensitivity with polishing. And at the dental clinic, you know, that all of these are reasons why after polishing, we apply a fluoride treatment. which should be standard really for all patients, but because insurance doesn't pay for it for adults because they're out of their cavity years, it's not standard practice in the United States to put fluoride on adult teeth because the effects are very minimal, but you know, it does remineralize after polishing. It will help to reduce sensitivity that the patient already has and could have been increased from polishing. So lots of reasons why we do fluoride, which is next week's lecture. Here's the last one. Frictional heat production may be detrimental to the pulp. Now you guys are in dental anatomy, you have Miss Simmons, right? So you learned about primary teeth. Primary teeth have thin enamel to just get them through those few years, 10 years, whatever, that the tooth is in the mouth. And then before it exfoliates, and then, you know, it's gone. So it doesn't need the heavy duty enamel just by nature, because the teeth are tiny for tiny little mouths. The enamel couldn't be as thick, or you'd have like giraffe teeth and a little tiny head. So the enamel's thin. If you can create quite a bit of heat with the speed and the friction of the grit of your paste and cause that thin enamel to generate the heat to the pulp and actually damage the pulp of a primary tooth. And remember, think about your lessons. A newly erupted tooth, very, very new into the oral cavity, even adult teeth, the pulp, you know, is larger, and then it kind of starts mineralizing, finishing the mineralization process internally. So, you know, you have to be very careful when you polish primary teeth and newly erupted teeth to really think of your rules of polishing: not too much grit, not too much speed, and light intermittent pressure, which we're going to talk about. So how do we minimize the detrimental effects? So polish only when conditions indicate it's necessary. When polishing, you know, get the appropriate cleaning or polishing agent. So this little indented bullet, if no stain is present, don't even use an abrasive agent. Use a cleaning agent, which will not abrade. If you do need an abrasive agent, use as little as possible. And I can tell you, I've worked in offices that I absolutely love, you know, many offices. And there are two that were my favorite, absolute two of the top 5 I've ever worked in. But their philosophy was to use a coarse grit on everybody. And I would clean them out of their children's paste every time I filled in. Like, you know, I'm like, it wasn't necessary. It was an old philosophy that was detrimental. I find I can do more with fine grit paste, and medium grit is like the exception to the rule. And I never use coarse. If I need coarse, you know, back in the day, I would have ultra scaled more, and then polished on those heavier duty stains. So you might still run into an office where they just use coarse across the board, so that one patient out of every 100 who needs a little more grit, you know, it's already there, they have it. They don't have to go in the drawer to get a medium grit or a coarse, which I think, you know, is just is a terrible philosophy. It's so unnecessary for 90% of your patients. They can use a medium or fine, usually a fine grit. So that bullet is huge. Use only the abrasiveness that you need, because the more grit in the paste, the grit, a fine grit has smoother particles. A medium grit has just a little bit more edgy, and a coarse grit is very edgy. If you've ever felt sandpaper and you felt the difference between fine and coarse, like coarse can almost, you know, just by rubbing it across the back of your hand, could abrade your tissue. It's so edgy. The bits and pieces on your sandpaper are so edgy. That's the same philosophy that's going on in your paste. Okay, so if you took coarse grit across, you know, your semi-gloss trim, you're going to see all this scratching going on your painted surface. And a microscopic level, that's what you're doing to the tooth when you use coarse grit. So you need to not just take that lightly. You need, you know, if you have to fill in a few offices before you get your job that you love and you're at 4 days a week or however many days a week you want to work, and all they have is coarse grit, trust me, somewhere they've got fine for the children. You just got to clean out the drawers till you find it. So apply, down here, the next bullet, apply to a surface as a slurry. What does that mean? That means that the tooth, like you'd never want to polish in a pool. If you're polishing the, say, number 30 and the patient's turned towards you, right, and number 30, sorry, wrong side of my mouth, you're righty and you're doing number 30, or you're a lefty and you're doing number 18. So the patient's turned towards you. I'll go towards my lefty people. All their saliva is going to pool in that area. And if you polish 18 and there's saliva that's pulled, and it's like, you know, you're underwater polishing, you're going to create quite a mess and aerosols and splatter. So you don't want that amount of water. But what you do not do is you do not dry the teeth until they're dry, like we do for instrumentation, to polish. You want them moist. Just like your mouth is moist right now with normal swallowing and carrying on. They're moist, right? You keep them moist like that. You remove the excess saliva with your suction, and you polish on a moist tooth. That allows the paste that you're using, which hopefully is already moist, to be what's called a slurry, like a moist little environment. Apply with an intermittent touch. So we're going to learn that when you polish, you don't press and just drag around each tooth with never lifting. You sort of press, drag, lift, press, drag, lift. And you go in proximal, mesial, drag, lift, you know, as the cup is spinning and you're pushing your little pedal. Intermittent touch. It allows air to get to the tooth. It allows air to get to the cup, so you're not producing heat. Okay? You don't want to overheat the tooth surface. It's uncomfortable to the patient. It could damage the gums, and it could damage any root exposure because you're creating a friction that's not, you know, that's also heat. And grit is creating more abrasive damage than you would have created at all if you'd used intermittent pressure. Avoid heavy pressure. It is a press and drag, but you're not bearing down on that cup, right, with like all your force. It's a rub and drag with a medium pressure. And you use the slowest effective speed. So you'll get to know your handpiece, your engine that you polish with, that's in your kit. And if you hear a whine, it's like a high-speed whine you'll get to hear, you know you're pressing too hard. So that's something you'll learn as we're practicing. And we're not going to get to polishing until the spring, which is actually good because you're going to learn it, do it on mannequin and on each other right before you go into patient care. So I actually think that's a good thing this year. We might carry that on for years to come. Contraindications for engine polishing. If there isn't any stain, any extra sticky plaque that won't come off with a toothbrush or stain, then you just, you can do, you can use a cleaning agent which doesn't have any grit, or just skip that tooth. If it's a newly erupted tooth, skip it, right? We talked about that pulp is still mineralizing from the inside. It's huge. You could damage it. If there's no plaque, why even touch it? Why have the patient go home and their tooth be sensitive? Significant xerostomia, right? We talked about you need to polish in a slurry. If this patient's mouth is bone dry, and I'm talking head and neck radiation, no saliva flow, they have to hold a cup of water all the time to constantly to moisten their mouth, constant, you know, there's not always, it's rare to see significant xerostomia. Usually you could put a little water and help them out. They swish it around their teeth and they'll stay moist to polish. But if they're bone dry, you might not be polishing this patient. You might be toothbrush polish with just toothbrush and some paste, and you do a very thorough job, floss for them, and then that might be it. You don't want to cause damage because there's no slurry to polish in. That minimizes the microscopic abrasiveness to the tooth. Rampant caries, right? We talked about pitting. What's more pitted than a carious lesion that is pitted all the way through the enamel to dentin? So you could drag on that pitted, you know, broken down tooth margins and further break it down, break it off, chip it away with aggressive polishing. Skip it, brush it, polish other areas that might need it. Demineralization is a lesser carious lesion, right? It's demineralized means there is pitting in the enamel. It has not broken through the enamel to the dentin, so it is not considered a carious lesion. Actually, demineralized areas are considered areas that could heal themselves with intervention. Patient's home care intervention, our fluoride intervention, not weakening the area with aggressive polishing. These areas could heal themselves, and that's, you know, the goal. So we don't want to reverse that process by pulling out fluoride that's trying to build up the tooth with our polishing procedure. Exposed root surfaces, right? You should have learned in dental anatomy that the enamel has a certain hardness that's just amazing. The root does not have that protective cover. So if it's exposed, you need to be very gentle and considerate of the root, including with your polishing, your grit, your speed, your whatever. You know, that should be part of your conscious awareness of what you're going to do and not do as you polish, what surfaces you're going to touch and not touch. Tooth sensitivity. We don't want to increase it. We already talked about that. We talked about the soft spongy tissue that might need to wait a week to come back and be polished. It could, you know, the little indented bullet, polishing right after a heavy duty deep scaling and root planing could delay healing. Briefly mentioned, but we're going to keep restating it because it's important that you know this, remember it. Gold or tooth colored restorations and implants can be scratched, that may be scratched shouldn't even be there. Will be scratched by an abrasive is how this should be stated. You must use the cleaning agents that do not have grit on gold. Tooth colored restorations, this would be your porcelain. That doesn't mean the little MO or DO composite. That's not the same thing. If a patient has a full porcelain veneer, or a veneer that covers all the facial of number 8, number 9, usually that's where you'll see those veneers. That would be another example. But we're not talking about, an occlusal composite. You can polish that. You just select your grit appropriately. But the gold or tooth colored restorations, the porcelain crowns, the veneer, or implants should not be used a grit on those at all. You should use the cleaning agent that puts a luster on the tooth. If you don't have a preparation of a little cleaning agent that's like single-use disposable or a cream paste, then you'll use a tin oxide. So about 15 minutes left. So we'll keep on going and then take a little break. Any questions, chime in anytime. So contraindications for engine polishing, right? We've already gone over quite a few, but here's some more to think about. If you have not gone over plaque removal with a patient and a patient's not demonstrating adequate plaque control, it could be a motivator. you know, we're not going to polish today. You need to learn how to remove these yourself and then come back. And next time you come in, we'll polish. I'll be perfectly honest, I have never done this. Nobody's going to charge somebody $140 or their child's appointment $120 with x-ray and dental exam and not polish their teeth. You know, you're going to get some serious, they'll probably change offices. They'll be so upset. So keep that in mind. It can be used as a motivator. You know, you have to learn to take care of yourself, and then we will polish next time once you come in with better, you know, home care efforts. I don't know anybody in the United States, you know, I don't know the whole United States, but I can't imagine this is common practice anywhere in our country. I would be amazed. But no, it's a thing. Patients with respiratory problems. Polishing may exacerbate breathing problems. This would be your asthmatic patient, your COPD. We're going to learn more about those when we have, you know, week 13 and 14, when you guys are training us up on these conditions. A patient with high susceptibility to infection transmitted by contaminated aerosols. A patient has active TB, we give them a mask if they didn't come in with one and march them right back out the door. We don't even let them open their mouth, because if they cough, there's aerosols. Can you imagine the plume we would create with polishing? You know, it's not even, we just don't go there. So that would be a high susceptibility to infection that can be transmitted by contaminated aerosols. Communicable disease, that would be also the TB, the COVID, the flu, all that stuff. So if somebody had the flu, we'd send them home, right? If somebody was living with a person who was just diagnosed with COVID within the past, you know, 14 days, keep in mind the difference between the flu and COVID. Historically speaking, patients are the most, can transmit the disease most readily with the flu once the symptoms appear. The problem with COVID is you can transmit the disease 4 days before you ever have your first true symptom. Like maybe you just wake up and feel tired, you're a little stuffy, but it's, you know, shoot, that's me every day. So I would never know I had it until the fever hit and the more severe symptoms. That's why, you know, if a patient's living with somebody with COVID, but they haven't, you know, they say, I don't have any symptoms yet, it doesn't matter, off you go. We'll test you, and then we'll see you after, you know, you test negative. Oops. Let me go back one. Make sure I didn't miss anything. No, I did not. Okay. So there's a term called selective polishing. You need to know what it is and you know, a little bit understanding of it. We already touched on it, right? We said if there's demineralization, don't polish it. Toothbrush it for the patient to help clean that plaque off. We're going to put some fluoride on it to help the remineralization process. If a patient has sensitive root exposure, we're going to think carefully about polishing that. Like, that's not in their best interest to get down there with a medium grit and polish away. So that's what selective polish means. All the things we've talked about, you know, a newly erupted tooth, you choose not to polish it. But selective polish goes a little further. If a patient doesn't have stain to remove for appearance sake, you would not polish. You would skip all the teeth except the ones that the grit, fine or medium grit of the paste is going to reduce the stain. You know, plaque, they can brush away, you can floss away after your selective polishing. So this concept seems like, oh, this must be something new, but it's been around since it was documented in Wilkins, Esther Wilkins' 4th edition back in 1976. That was a long time ago. So it's just not, it's not commonly accepted. Like, I don't really get stain on my teeth. That's extrinsic, and we'll talk about that in a little bit. So, you know, I have, you could choose not to polish my teeth if we followed this 1976 concept. I would not feel like my teeth had had their cleaning at the office. I'm like every other lay person out there. I want my teeth polished. I love that right after the dental office visit, that smooth, slick, super duper clean feeling where the acquired pellicle's been removed, and, you know, and everything just feels so slick. So, you know, the philosophy change was a response to concern, I'm down here at the third bullet, that abrasives remove the fluoride-rich outer layer of enamel, and that since polishing was for aesthetic means just for the looks, just to make it look better, not healthier, just aesthetics. The practice should be limited. The change of dental hygiene care was not well received. Patients felt their treatment was incomplete if all of their teeth were not polished. So then we went to the 11th edition of Wilkins for selective polishing, and it was redefined to say no scientific evidence exists that has definitively determined how much enamel is potentially removed during polishing. And since the enamel has the capacity to remineralize if microns of enamel are removed, microns meaning microscopic layer, it may remineralize in time. So it'll fix itself. We polish, we remove a microscopic layer with that acquired pellicle, that surface plaque, and a little bit of stain that was there, and it'll repair itself in the right conditions. The patient's not drinking 5 sodas a day, and they're brushing, and, you know, there's some fluoride involved. So the recent evidence-based decision-making has changed the protocol. Attention must be given to the positive and negative effects of polishing. Professional judgment based on the patient's needs and request. And so the last bullet, the RDH, the dental hygienist, right, registered dental hygienist, can polish all teeth, stained and unstained, but must be prudent, must be carefully selective of the cleaning or polishing agent according to individual needs. So as I said, I don't get stain. Like, I don't have that brown line stain or whatever. My teeth have intrinsic staining because I love blackberries, coffee in the morning, and tea in the afternoon. So I truly, with aging, I've gotten staining, but you're not going to polish it out. It is in the tooth surface. So polishing just sort of brightens and makes my teeth feel better, but it doesn't remove any discoloration that's visible. So for me, you would use a fine grit paste. There's no need for anything else. Or you could use a cleaning agent that just sort of fluffs, you know, polishes around with no grit to help reduce plaque. So we need to understand stain in order to choose the best technique and products to treat it. So patients, they're talking about patients, you know, you look at the tooth. One, is the stain sitting on top of the tooth and will remove with an instrument such as a scaler or the polishing cup? Or is it intrinsic? Is it just a broad discoloration in the tooth? Techniques and products to treat it will better meet the patient's expectations for polishing while limiting their risk, right? The less grit, the least amount of grit needed is what you will use. You won't just say, I'm using coarse because one patient out of every 100 is going to need it and I'll have it on my tray. No, if you have to get out of gloves to get a medium grit, because all you usually use is fine, then that's what you'll do. You won't subject everybody to the most aggressive grit just for that occasion when you need it. In the selection of the teeth that need to be polished, and in the selection of the correct agent to meet the individual needs. So what are those 2 bullets talking about? selecting whether you use a cleaning or polishing. So it's like just redefining again in a different manner. We've talked about all these things. We've talked about these 2 red bullets. After you scale, remember root planing just means, scaling kind of means you remove the moderate deposits. And then root planing is where you go back and you remove the smaller little bits. What's left? Maybe when they came in, they had a lot of stain everywhere, but because it was on top of calculus super gingivally, and when you removed the calculus, the stain came off, your initial thought that you were going to need a medium grit paste, you need to reassess. Now this patient needs fine, right? Once the patient's polishing needs are determined, you use the appropriate one. So it's hard to see in this little tiny picture, but this again is talking about delicate restorations, porcelain, facial veneers that cover the whole front of a tooth, porcelain crowns, and gold. If this was bigger, you would see all these scratches across it. And what I wish they had on the left, and I tried to find a good picture this weekend, I just couldn't find it that met than what I wanted it to do. If I would wish it had a picture beside it of what a newly placed, polished by the dentist with a polishing, not a grit, but a agent that puts a luster on the gold and the porcelain next to this, because then you would really see the scratches, the difference that you could have put on this beautiful restoration that had this nice luster and sheen to it, and now you've made it plaque retentive, because these are not going to remineralize on these, right, on these artificial surfaces, the porcelain and the gold. Once you put a scratch there, it's there forever until a dentist comes back with the luster agent and polishes it out. So, you have to be careful what you polish, because you could create permanent damage to something that, the patient paid for and expected to stay beautiful and shiny and plaque resistant. So I already said what a cleaning agent is. You need to know these 2 terms and the difference. A cleaning agent is non-abrasive. It will remove biofilm. What is biofilm? Biofilm is plaque. It is the acquired pellicle, right? The little saliva kind of coating on the tooth that plaque will grow in. And it will give the patient the feeling that they have a clean, surface, that sort of slick feeling. Especially once you floss, which is part of polishing, is flossing properly for the patient. The patient presents with stain. Patients presenting with stain will require a polishing agent, which has some level of grit. And there are various grits, which we've alluded to. And we've always said, choose the least abrasive grit to effectively remove the stain. Educate your patients. We want to use the least amount of grit. We've learned it removes the fluoride layer. It can weaken, the enamel microscopically. If it's rare that you're going to find an office that will apply a fluoride treatment for adults, because it's expensive. It's time, it's a little bit of extra time, and insurance isn't going to cover it for the most part. So you're not remineralizing, heavy duty fluoride to build up that surface. So you want the patient, for their own health, because if stain's collecting heavy duty stain, they're not getting the plaque off in that area as well, right? And so you want to motivate them to clean their teeth properly. That'll help reduce stain, that'll reduce what you need to do in the office, and it's a win-win. You need to identify the origin of the stain and advise the patient how to avoid future staining, and recognize the patient's desire for polishing. Like myself, I don't need polishing. but I enjoy it. I enjoy that feeling. I've had it since I was a child when I go to the dentist, so I expect it, even though I know what it can do to my teeth. So I expect my hygienist to use a fine grit. It says principles of polishing. You remove what you can prior. You can use ultrasonics. You can use air powder polishing to help with stain removal. You'll learn about those next semester. Sorry, this is being extra sensitive. Let me see, that was that. Let me just see this principles. Okay, so we'll come back and we'll start with this principles of selective polishing. If you set your timers for 9 minutes, I'll do a roll call at 10 minutes. And you guys can have a little break. I'm going to mute myself. All right. So I threw up a philosophy of dental hygiene on your sent to your email. Let me double check that it went.
I got it. I'm printing it already.
Okay, it has the wrong date, but quite honestly, I was trying to figure out this CAC issue, and I was like, you guys know what date it's due. So it says 2017. You know, it's due. I'll say it again, just in case you printed it out. It's due Tuesday. Oh, wait a minute. What day is it due? We said week 12. Yeah, so it would be Tuesday, November 17th. I gotta go back to my important dates. Now I'm questioning myself because I don't want to say something that's different than your important dates. DTCC courses. All right, let me triple check. So we got all the same. Course documents. Oh, summary. Okay. It would help if I was in 101 and not 111. Let's go back. There we go. Content. Competency. Control. All right. Well, I could find everything but what I'm looking for. I have to go back to my 101 binder. If you guys find it in the meantime, let me know. I just want to have to dig through my binder right now. I thought I could get to it quickly. So, Sydney, I'm still looking into the CAC issue. They just sent Dr. Darrow's info as well. And she has a CAC appointment Monday, so I got to figure this out today. So, yeah, I'll keep trying to figure out what the heck's going on.
Okay, sounds good.
Okay. So I know Sydney's here. Tyler, are you here?
Yeah, I'm here.
Tiffany? Yeah, I know you're here. You printing off. Melissa?
I'm here.
Hannah?
I'm here.
Okay. And Elle?
I'm here.
Darian?
Here.
And Daisy. All right, perfect. Anybody have any questions, please chime in anytime. So we're back onto our polishing. You know, the first part takes the most time to go through. So even though we're not halfway through polishing, it's, you know, this is sort of a repeat and I can skim through these much faster for the next like 10 slides or so. So avoid heavy pressure, use intermittent touch, which we talked about. You sort of press, drag, lift off, press, drag, lift off. You don't even have to lift off that far, just a little bit, just so there's air flow between the cup and the tooth, and the slowest speed possible. So, you know, I mean, you can expect these are important things for you to know, right? If you're going to have something in your hand that you can remove part of the patient's body with, there's enamel that's in fluoride layer, you're going to be expected to know how to avoid that and reduce it. That's a huge thing, and not to be taken lightly just because we all always get our teeth polished and never think about it, right? It seems so fluffy, puffy, kind to the tooth, but in the wrong hands with the wrong mentality, you could cause damage. So this is just a review. We've already talked about all those things, talked about the abrasive material, that there are cleaning agents which don't have an abrasive. So know, we talked about that. You can read through that. This is 1, 2, 3, 4, 5, 6, right in line of how you can increase or decrease, you know, the detrimental effect of polishing, the abrasion of polishing. So you should know that list. You probably saw this. Oh, this thing is so sensitive today. You probably saw this in Mrs. Simmons' class or in Miss Myers probably as well. The hardness, right? The MOHS, hardness value of dental tissues. So enamel is a 5, dentin is a 3 to 4, cementum is a 2.5 to 3. And look, you know, agents, abrasive agents and polishing, some of them are almost twice what enamel hardness is. So there's no question you can scratch. You know, 9.5, that's almost double the 5 of enamel. So it's almost twice as hard as the enamel you're polishing. Boron, you know, aluminum oxide, like you can go right down the list. The emery that you sharpen, you file your nails with, that same grit could be in a polishing agent. So it's, you know, you have to understand that yes, enamel is incredibly hard, but some of the abrasives that it can be used in polishing agents that you will use professionally can be much harder. And that's why this microscopic scratching occurs. And then it goes down to the 3 and the 2, the 0.05, 0.04. So, you know, you don't always know what's in your paste, but this is a good scale if you're trying out a new product, a new company, and you want to see what they use and see how abrasive it is. So cleaning agents are round, smooth, non-abrasive particles. They more put a luster and a polish on the tooth. I shouldn't say the word polish because that's such a general term we're talking about, but there's more of a luster to it. Sort of like using a fine cloth on your, you know, your fine wood countertop or something that's been handed down for generations. You use your nice polishing spray and you use your nice soft cloth to put a luster on it. If you're doing your car and you putting your wax on, you go after with that nice cloth to put, you know, it's cleaning it, but it's buffing it, but it's buffing it gently so there's no scratches to the surface, right? That's what a cleaning agent does. An abrasive agent is used for biofilm that's, you know, usually stained and attached to the tooth. We've already talked about contraindicated for gold, porcelain, implants. There are a number of products, excuse me, there are a number of products to use for these surfaces. In our clinic right now, we're using NuPro Shimmer. It comes out as, looks like a toothpaste, but it doesn't even have the grit of paste, of toothpaste you use at home. It's just, it puts a nice high gloss on the surface. There can be additives added to your paste that you use for your polishing procedure, like fluoride. You should have learned that calcium and phosphate will encourage fluoride uptake into the teeth. And they used to think it was just fluoride, and now they realize you need the calcium phosphates to attract the fluoride and hold the fluoride to cause the mineralization process. So, you know, that's why you had chemistry before you got into dental hygiene, so you could understand the attraction of different components and what that means. Whitening agents and desensitizing agents. So if you do have a sensitive patient, there are some agents you can polish on the teeth that will help to reduce sensitivity. So where it all began, the port polisher. It is just, you know, history is important. You need to know where things came from. So when I graduated in 1986 from dental hygiene school at Delaware Tech Community College in Wilmington, the year, I think my second year of hygiene school, I had to port polish one patient. So that's this top little guy. I don't know if I can drag and make him any bigger. I can't. He's just a little metal handle, and there's a disposable wood toothpick on the end that's flat, 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 flat. And you would take up your paste on that, place it on the tooth, and then drag that wood tip over each tooth. You know, it's like 2-3 millimeters wide, flat surface of the tip of that wood tip. So I had to polish 2 to 3 millimeters of the tooth at a time, every tooth, distal to mesial, buccal, lingual. You know, thank God they did away with that. Even when I graduated in '86, which probably seems like a zillion years ago to you guys, that seemed archaic to me. So thank God they took that out of the curriculum. That was crazy. But, you know, it was a good understanding that if I were to go on mission trips, if I were to do, you know, things in different countries, I had ways to get around not having electricity, right? I mean, sometimes you need an eye opener that we're just so used to everything electric that there you can't, well, we just can't do anything. That yes, I might be able to reduce a patient's plaque and some stain, and at least on their, you know, their front teeth, to give them some confidence that things are healthier and look better. And I don't have to have electricity. So it was kind of an education for me, but I'm glad it's not in the curriculum, and we can just show you a picture and you know that there is a non-electrical start to polishing before we put a little rubber cup on the end of a big handpiece and started polishing with a spinning paste. So a long, thick, I'm on the third bullet down, instrument handle. Oh, I'm sorry. That's still describing the port polisher. So look at the handpiece up here. When I graduated and I went into work in offices, my first handpieces were dental handpieces that the dentist had got himself a new one or herself a new one, and they no longer used. And, you know, not every office I worked in those first few years, but a couple. So it was the dentist handpiece. It just didn't have any water going to it. And they would put a restrictor on the end of it. So no, it's already long. And then they put 1.5 inch restrictor on it, and then it attached to the handle. And back then, most of our cords were coiled, so it was already dragging and pulling against you. And most of my hand pain was not so much due to instrumentation, but the holding the polisher against this terrible heavy counterbalance of weight. And it was very, very heavy, like 3 times the weight of what you guys use. It was double the length. The coiled wire was pulling against me. So my goodness, thank goodness ergonomics and, you know, and operator health became a thing, and handpieces became less expensive. Keep in mind, some of the reason that we use the dentist handpiece and then they would get themselves a new one is because there really weren't great hygiene handpieces back then. And they cost about $1,200, where now you can get one for about under $400. So, you know, the cost has come down a long, long way. So that has allowed dental offices to be able to afford to provide their hygienists with more, you know, products that are easier on the hands and body. But knowing where we came from is always kind of good to know. You know, you get frustrated sometimes, but just realize it's a lot better than it used to be. So this is a picture of what yours looks like. And there's one down where the hygienist is holding it in their hands. And that's more similar to yours even. And they're smaller, they're lighter. They're a low speed. They don't need a reducer on them to reduce them from high speed to low speed. They are only low speed for hygienist use. And they have a Profi angle that you can attach. They are air driven. It operates by use of compressed air at a speed between 0 to 40,000 RPMs. That's when this baby is squealing with a high-pitched whine noise. If you hear, you know, an engine noise that's a high-pitched whine in your car, you're gonna be freaking out. That would be like if you're in park and your foot slipped, you know, you thought you were on the brake, but you were to put it into drive, but you were mistakenly on the accelerator and it goes, "Wah!" That high speed pitch. That's what this guy will do. You never want to polish at 40,000 RPMs. When you use the rheostat, that's the little pedal guy that you press that activates the air to the unit. That's what controls how fast this goes, is your foot. So that's a learning process in itself. And when you press on your rheostat, you don't put your whole foot on the middle. You don't cover the rheostat with the middle, you know, of the rheostat with your whole foot. You put your big toe and a couple of the toes part of your shoe on the edge of the rheostat, and that'll give you your lower speed and more control. So, you know, those are techniques you're going to learn, but the more you hear it, hopefully the more you'll remember. Use the edge of the rheostat, not the whole thing. Handpiece hoses, you know, this is ideal where the hose is in line with the handpiece as opposed to this contra-angled attachment and the coil. This is what I had. It was very dragging against me. I was pulling against it to do what I needed the handpiece to do the whole time I polished, you know, 7, 8 patients a day. It was very fatiguing. So these are different cups. Just ignore the attachments. Mostly we use disposables with the cup already on it. So let's look at this picture. Picture 37. It acts as the working end of the system. And this is, we call this is angle attachments. Typically, you're going to hear us say your Profi angle. Do you have your Profi angle? There are rubber polishing cups, and there are bristle brushes that are used for polishing. And there are other attachments as well, but those are the main two we'll use in clinic. Ignore the threaded, the button, you know, ignore those two slides. It's important to know there's a webbed cup. It's a little stiffer and it holds less paste. Mostly we like to use the one that doesn't have the little webbing fingers inside, but it's ribbed, and that allows the cup to flex more around, because remember, even though this is a round Profi cup, the face of it is flat, and we're having to adapt that to the curvatures of the tooth. So it has to flex, to bend and drag across the curves of the tooth. Your bristle brush attachment is used only on occlusals, never near the gingival margin in any capacity. And what do you need to polish? Well, you need your cleaning agent or polishing agent. You're going to disclose first. The applicator used to disclose, right? Your cotton tip, your air water syringe, saliva ejector, and gauze, your dental floss or tape. And there are things called finishing strips, which are actually little flat. They look like wide flossing tape, which is like floss that's super flat and super waxed and kind of a little bit fatter than traditional floss. But this flossing tape actually has sandpaper grit on it that's super fine, or can be kind of fine, but not super fine. And it's used for stain removal by the hygienist interproximally. It's not common to need these. Quite honestly, I don't think I've ever used one as a hygienist, because I've used my instruments and handpiece to do what I needed to get done. But it is something you need to understand. You need to know about finishing strips. Boards will ask you about finishing strips briefly, probably on just one question. It'll be one of your A, B, C, or D, or E's. And you need to understand what they are. And just think of it as floss that has, that is embedded with like a fine sandpaper, so that you can floss in a proximal and scratch off any stain buildup. So what is the procedure, right? We're going to look and see what two surfaces we want and feel we can safely polish. We're going to disclose the patient's teeth and have the patient look at their teeth to see what plaque is there. We do this very early in the appointment, and whether that's part of our home care procedure. And we have them remove the plaque during patient education, if we're talking brushing that day or flossing. And then we're going to scale and root plane to remove the stain that's embedded into calculus or heavy plaque. And then we're going to select our appropriate abrasive agent. Why do we use this? This top bullet seems like blah, 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 right? Blah, blah, blah. Yeah, whatever. But it's not. Follow an established sequence to proceed from one group of teeth to another. Consider efficiency of time and motion. So when I polish, I tend to polish all the facials. I go back to the linguals of the upper. This is when I use that side, like my belly button is at the patient's ear with a side straddle, you know, that we've alluded to way back in week 2, 3, and 4 of clinic. I'm not at all the way back between their elbow and shoulder at 8. I'm up around their head at 12, 11, 10, and maybe 9. And my lefties are going to be at 12, 1, 2, and side, just keeping the straddle the whole way around 3, so that you can polish all the surfaces using direct vision, indirect vision, and the patient's head tilt to just keep on going. If you follow an established sequence for polishing and for instrumentation, you won't forget if you've done something. You won't go back and do it again because you forgot you already did it. You won't miss an area and not establish a good technique that the patient benefits from because you left an area dirty with your instrumentation or your polishing. So with following an established sequence to proceed from one group of teeth to another, and this is what Miss Phillips, this is like her big pet peeve when people bounce all around, right? You've heard her talk about that. So this is important. And why is it important? You save time and motion because you've established a sequence that's efficient and you don't forget to do an area. You want to dry teeth to control moisture. That doesn't mean make them dry like we do with instrumentation. It just means don't polish, because this is misleading and I apologize for that. It just means don't polish in a pool of water. You're not submerging your prophy cup in a pool of saliva and saliva is spinning and flipping all over with that spinning cup. The tooth is moist, not soppy wet. Build a rubber cup with your paste. If you're using bristles on the occlusal, you're going to clean and polish those, or when you do, not if, it's required at our clinic to use your bristle brush on occlusals, and then you rinse the teeth as needed. If a highly abrasive, hold on, there we go. I had to get rid of a pop-up. If a highly abrasive agent is used to remove stain, it must be followed by the use of a fine polishing agent. So I cannot say I have never used coarse grit because there are times when I have, only on the enamel, but when I did, I only used it in that site that needed it. So then you would go back to a fine grit and use fine everywhere else that didn't need the localized coarse grit. But if you use a highly abrasive, which would be your coarse grits, you must follow it up with a fine grit polishing agent or, super fine. Use just enough intermittent pressure to make the rim of the cup flare slightly. So flaring the cup is a technique, the technique for polishing you're flaring and dragging the edge of the cup. So the whole cup doesn't flatten on the tooth. You kind of tip it slightly to cause the flare around the curvature of the tooth and to be able to drag that tip. So this is showing correct placement. The whole cup is very close to the tooth, but this little bottom edge is lifted slightly off so that you're tipping into the top of your spinning prophy cup and dragging it across the tooth surface with short overlapping strokes. There's your mesial, mesial position and your distal. See how you roll it interproximal, just like you roll a metal instrument interproximal. You do the same with this rubber cup. You guys could read that. We typically do not use finishing strips for stain removal interproximally. Just know it is a thing. Boards loves to talk about it. At least one question they'll throw it in. So you need to be aware of it. And I can't say there aren't hygienists who have used finishing strips. You know, have not. There are hygienists, let me restate that, who have used finishing strips. Occasionally, like rarely, occasionally. I'm just not one who ever thinks to use them. I'll just go back in with my instrument, turn it until I get off what I need to get off, you know, interproximal, because I find finishing strips hard to get in between teeth. They're thicker, they're a little heavier to manage, they're wider to get between the contacts. So they're not something I'm a fan of myself, but I know some hygienists have successfully used them and like them. You know, that 1 out of every 100 patients that could benefit. So here's something important to know, right? We talked about, we disclose at the beginning with our patient education. It helps us see where the plaque is heaviest so we can kind of have a plan in mind when we decide to polish. We kind of already know, even after scaling, there's a lot of plaque interproximal. I'm going to be polishing those interproximals well, or cervicals well, or whatever. But when you're done, you're going to redisclose to evaluate if you've missed anything. So that's how you're sure you got it all off. You redisclose with a pink disclosing solution. And then you have the patient rinse, of course. You dry the teeth just lightly. Now that we're not using air so much, you might just use the suction for drying the mouth a little bit and then just look in. You rotate the mirror to view the proximal, right? Because you can't see the distal with direct vision on the posteriors, especially molars. So you need your mirror. And if there's pink, then you're going to repolish that area and check again. And then consider a fluoride application to replace fluoride loss during polishing, which is standard procedure for us at the dental clinic. And the care of your handpiece is something you need to understand. They do have to be lubricated from time to time. They are put in through the autoclave, but never, ever, ever submerged underwater. So that means you do not put them in the countertop ultrasonic you guys have been checking out on. You do not do that. They get wiped, they get lubricated, and they go straight to the autoclave, not submerged underwater. You will ruin a handpiece if you fill the air tube with water by submerging it. You'll destroy it. There's the lubricant can that has a little point on it. It's always put in the smallest. There's 2 tubes on the end of your handpiece. It always goes in the smaller hole. Both tubes are different sizes, like it shows here. There's one that's smaller than the other. You put it in the smaller hole. So if you're ever in your office and you have to lubricate the hand pieces and you can't remember, your handpiece comes with a picture just like this. Almost everyone does. Usually the back of the lubricant can will have this picture to remind you to put it in a smaller hole, because again, if you clog up this hole with a big squirt of oil, you could ruin the handpiece. So you don't want to do something just to do it, check off that box. You need to do it correctly, or you could be paying $400 or $600 or however many $100 to the office or that handpiece, or repurchasing a new handpiece for yourself while you're in hygiene school. So you clean the debris away, wipe it, clean. You can use alcohol or gauze immersed in alcohol to wipe it. Do not use a wire brush. You lubricate it, put it in your autoclave pouch, and autoclave it. So after saying all that, what you need to know is that you don't get to take care of your handpiece at the Dover Air Force Base. Just like you don't get to run your instruments through the Miele, which is the big dishwasher. It's like a tabletop ultrasonic times 100, right? It's a big dishwasher. It's the high dollar version of ultrasonic for your instruments. And then you don't get to bag your instruments and put them in the autoclave. It's the same thing for your handpiece. You will send it in the tub to the SIPSI in the gray tub, and they will take care of your handpiece. Okay? So you need to understand the procedure. You need to understand that it's important that you know which hole to put it in. Nobody's going to expect in 2 years after you get hold of your handpiece again and you're taking care of it yourself, or the offices, you're going to remember. What I want you to remember is, oh my gosh, there's 2 different size holes. I need to find out which one to put it in so I don't ruin this handpiece. Okay? So these are important things to know, so that they are an issue, that you could destroy a handpiece by putting it underwater, so we don't put it in the ultrasonic, and that you have to know which hole to lubricate. So look at your lubrication bottle. Usually it'll tell you. Okay, so let me stop share on that. And go to my Word docs. That's our objectives that you guys are going to use to help organize your thoughts for the quiz. Give me 1 second. I'll share in just a second. I'm just that's the polishing procedure. Huh. All right. I thought I had it on here. Thought it was part of my PowerPoint. I need to go over stains and deposits. So let's take a 6-minute break, get a drink of water, and this will be our second break of the day. And we'll come back, take roll call in 6 minutes. I got to email this to myself. I'm going to mute myself, but if you have any questions, chime in. I'm here.